So I'm going to be talking about anti-fat bias in the ED. This is an important topic because the ED is very fast-paced. We do a lot of heuristical thinking, so our implicit biases are always going to be in the passenger seat, even if they're not driving the car. And it's important that we are aware of our various different types of biases so that we can challenge them and treat all of our patients with the equal respect that they deserve. Also, a quick note on language. Fat activists have called for the word fat instead of obese or large or any of the other words that you hear used. I'm not suggesting that like we change this language in our notes or on rounds in medicine, but for the purposes of this presentation, I'll be going back like and forth between words like obese and fat just based on context. Okay, so learning objectives. First, I'm going to touch on the history of BMI. Then I'm going to explain the idea of weight stigma and the epidemiology of obesity. I'm going to introduce the idea that obesity is not always a risk factor, go into a little bit of nuance with that. Exposure to weight stigma is a risk factor. Weight is not modifiable or not as modifiable as we've been taught to believe. Then I'll talk about intersectionality in this context, and then lastly, some takeaways for your shift.
Milo, the slides are not advancing.
You can't see the learning objectives.
No,
Hmm.
Okay.
now it can.
Yeah.
Okay. Okay, we can see the BMI chart.
Yes.
Yeah, the
Okay.
only thing is that if you want to just slide your little green box over to the right a little bit, you got a little bit of that like white piece on the edge there that I don't think you intend, and we're missing a little bit of your slide, it looks like. Yeah, we're cooking with grease. All right, go ahead.
Well, I need to see my presenter view. So, oh, I can shrink. Can I shrink the faces? Is that
You can
is that
shrink our
gonna work?
faces. That's fine.
Like,
You
is
can
this
shrink our
better?
faces.
Okay. So going back to can everyone see? Can I get a thumbs up, Kelsey? I can only see your face. So, okay, great. All right, so this is a BMI chart. I'm going to talk a little bit about the history of BMI. Going back to the late 19th and mid 20th centuries, there was the eugenics movement going on. There was this very bad association that initially started to be made between fatness and Asian people and Black races. And there's this jump from that to fatness being aesthetically undesirable. A further jump is then made to fatness being unhealthy. So there's this general conflation between beauty and appearance defined by white beauty standards and health. There's other concerning nefarious associations also being made during this time period between race and intelligence and gender intelligence. And there's a lot of pseudoscience going on. So then moving into the mid 20th century, where health insurance companies are on the rise, there's this big investment in categorizing the population to make risk assessments so the insurance companies can say, we want to insure these people, we're willing to take on this risk. We don't want to insure these other people, we're not willing to take on that risk. Standardized weight tables are created. And then in 1951, there was a very important paper titled Obesity and Its Relation to Health and Disease. And it was co-authored by a group, four of which were executives in the health insurance industry. And this paper analyzed existing policyholders, almost all of whom were wealthy white people, based on their weight, morbidity, or immortality. And it was designed to create these like buckets of overweight and pathological overweight individuals. So this paper had sweeping claims with not that much scientific support in it. Claims such as 95% of overweight is accounted for by overeating, which we know now to not be true. This paper also had huge traction given the status of the men that wrote it, both that they were in the healthcare world and also that they were in the insurance industry. So around the same time period in the 1950s, a man by the name of Ansel Keys, after studying a population of white men, created this bell curve plot for weight for height proportions. Um, Notably, Ansel Keys had a lot of nefarious ideas. He was very fat phobic. He believed fatness was ethically reprehensible. So this is who created the BMI. So from his data, it was extrapolated that the mean of this bell curve of the population that he studied, their mean weight for height ratio must be the ideal. And so then that was further extrapolated to the ideal being the measure of health, for which other bodies can be compared to as unhealthy. Despite him being unable to produce any correlation at that time between his BMI categories and cardiovascular disease, which was his goal that he was setting out for in his project. This chart was so much easier to use than the weight for height charts created by the insurance companies that it became the predominant classifier for weight. So a little bit later in the 1970s, arbitrary classifications superimposed onto this bell curve were made, and they deemed that overweight or obese categories be above the mean, and then the ideal BMI was 18.5 to 25. Just a little bit later, WHO and some other international health organizations decided that they didn't want to call it ideal BMI because that sounds loaded with moral and aesthetic judgment. And so then they changed ideal BMI to healthy BMI. So there's a lot of editorializing going on in this process of coming up with these weight for height categories. Um, and so now the BMI greater than 30 is classified as obese. Okay, weight stigma. So weight stigma is negative attributes that we're taught to associate with obesity. These are attributes like poor self-control, being lazy, lack of moral character, unattractive, lack of willpower. Obviously, these are things that are not true, but these are things that we're kind of raised, have this association, and contribute to implicit bias. As I touched on a little bit in the last slide, weight stigma contributes to what we choose to pathologize. So it contributes to what we choose to study, what we choose to focus on. A lot of research on weight loss is driven by a dislike of obesity rather than strong scientific evidence. So comparing how we think about overweight individuals to how we think about underweight individuals can also bring some clarity to this idea of weight stigma, specifically fat phobia. We know that being underweight has huge health risks and increased mortality. However, there is not this same person blaming stigma associated with being underweight like there is with being overweight. It's a huge jump from this anti-fat bias that we know is based in white-centric beauty standards to the idea that being fat is bad, and then another jump to the idea that it's unhealthy. And then this final huge jump that is made to it being your ethical responsibility to have your weight controlled and to be healthy. And thus, it's your fault personally if you are overweight and unhealthy. There's a lot of evidence that shows weight bias increases as individuals go through medical training from when they start medical school to when they're ending. And then there's also studies showing that weight bias is pervasive amongst subspecialties of medicine, but it's worse in procedural specialties, likely because a lot of the tools and techniques that we're taught are not made to accommodate large bodies. Okay, so who is obese? I just want to touch on a little bit of the epidemiology here. I have this lovely amorphous figure to represent intersectionality because that's kind of the theme of the epidemiology of obesity. So a 2024 study in the Journal of Racial and Ethnic Disparities found that access to healthy foods and state minimum wage policy predict obesity rates, with a lack of healthy foods increasing the ratio, while a higher minimum wage reduces it. So we're talking about access to food, we're talking about income, both contributing to obesity. Um, in the same study, Black and Hispanic adults who experience some of the highest obesity rates in the US are disproportionately affected by both income inequality and poor food environments. So there's a lot of intersections between marginalized race, low income, poor food access, all contributing to who is obese and who we are talking about when we have weight stigma and we are pathologizing this disease process. Okay, so this is the most contentious thing that I'm going to push back on a little bit. Is obesity a risk factor for metabolic disease? I'm not here to say that it is not a risk factor. I'm just here to say that one, the answer is not quite as simple as we are taught to believe, and also ultimately our attitudes towards fat patients shouldn't be changed by the fact that obesity is a risk factor for many diseases. So yes, in some cases it is, and other cases it's not. Most of the time, though, we really don't have adequate evidence of a causal relationship, mostly just correlatory studies. So being overweight is not inherently unhealthy. Gaining weight is not inherently unhealthy. Losing weight, obviously, is also not inherently healthy. I was pretty surprised by how much literature calls into question the idea that being obese or overweight is unhealthy. I even found this AMA issue brief that was written in 2018 titled Fat Liberation and Eliminating Weight Stigma in Medical Education. I was actually shocked to find that title of an AMA issue brief, but it was really helpful for making this presentation. In a study performed by the National Center for Health Statistics, published in 2018, it was found that relative to people with normal weight, people who were overweight had a minorly reduced risk in mortality, whereas individuals who were underweight had an increased risk of mortality. Weight loss in a cohort of overweight patients with type 2 diabetes was an independent risk factor for increased mortality. A similar association was found between weight loss and mortality in healthy older adults. There was an RCT in 2016 showing that in overweight adults with type 2 diabetes, weight loss was an independent risk factor for all-cause mortality. And then one more statistic about obesity being a risk factor. A paper in Clinical Obesity published in 2018 showed that obese patients with other metabolic disorders like diabetes did not have an increased mortality compared to lean individuals, suggesting it's not an independent risk factor. Okay, so on the flip side of obesity, whether or not obesity is a risk factor, we do know that exposure to weight stigma is a risk factor for many things, including depression, anxiety, increased substance use, binge eating. It's also associated with increased food intake regardless of BMI, increased inflammatory markers like CRP and cortisol that are associated with metabolic syndrome. And there's also association between long-term cardiometabolic risk and increased mortality. And all of these studies controlled for obesity versus exposure to weight stigma. Also, on the AMA briefing that I mentioned in the last slide, it touched on the high prevalence of eating disorders amongst physicians and feelings of shame and self-hatred that a lot of overweight and obese physicians have about their weight, likely in large part due to the stigma that we are taught to hold during training. So continuing to proliferate anti-fat bias is harmful both to us as physicians and also to our patients. Okay. So is weight a modifiable risk factor? Our bodies have really good compensatory mechanisms for gaining back weight if we make significant effort to lose it. That's why almost all of the contestants on Biggest Loser gain back all of their weight, if not more, after leaving the show. After a year of intentional physician diet directed weight loss, 35% of patients are going to gain back all of the weight that they intended to lose plus 5 pounds. 60% maintain their initial weight. And then within 2 years, more than half of those patients are going to gain back any weight loss from diets. There's also a lot of evidence for harm from dieting. Granted, this was like one study. This was a poster presented at an AHA conference. It showed that 20,000 patients undergoing intermittent fasting, specifically restricted eating periods to 8 hours a day, was associated with a 91% increase in risk of death due to cardiovascular disease. So this is all addressing the contribution of diet, which is like one piece of the obesity puzzle, which has some modifiability to it, of course. But we're even seeing data that just choosing to change your diet and making those efforts isn't necessarily going to change your weight. There's a lot of other factors that contribute to being overweight as well, like genetics, income, where you live and your food access in that area, nutrition knowledge, how much are you working? As in, do you have time to meal prep, go to the grocery store to buy healthy food, as well as disability. Do you have the ability to move around and do exercise? Do you have the ability to go to the grocery store and cook? All of those things. A lot of these are not modifiable. So for
All
folks
right,
that
Milo,
still
real
feel,
quick, your
yeah,
slides are still like they're a little too to the left. There you go. Perfect.
okay. Um, how to fix this so that I can see my notes? Um,
If the only way to do it was the way that you had it before, it was fine. You could see everything. Just it was a little cut off, but that's okay. Your point is across.
okay. Just to share with you what's on the slide, there's a picture of SNAP, uh, protest for raise the minimum wage, some kids in a cooking class, and Prospect Park. So if you are still feeling compelled by the idea of you don't want your patients to have obesity, you want to help your patients get their weight under control, even though I think you should be compelled to not focus so much on that. Your zone of impact is not going to be at the individual level. It's really going to be focusing on public health efforts and general well-being. So thinking about having really good SNAP benefits for low-income wage folks, for safe outdoor recreation spaces, for nutrition and cooking education in schools so that kids can take those skills home and cook healthy for themselves and their families, for schools to have nutritious school lunches, increasing minimum wage so parents have time to meal plan and shop and cook for themselves and their kids. This is going to be the answer for folks actually trying to solve the obesity epidemic, and it's not going to be individual interactions. To be fair, I don't see us trying to intervene in our patients' weight a lot in the emergency department, but I do hear us talking about it. I do hear us talking about our patients being very overweight with this kind of undertone of what's going on with them right now is related to them being overweight and it's their fault. And that contributes to how the team is viewing the patients and ultimately how we take care of them. Okay. So for your next shift, just some takeaway points. So be mindful of how you speak about overweight or obese patients to them, to your fellow healthcare workers, to medical students, especially because of the data showing medical students' weight stigma bias is increasing over medical training. We don't want to foster those negative attitudes in our own minds or those of others. So be careful what you say. Be thorough when you are taking care of obese patients. Don't blame the patient's obesity for their illness right off the jump and overlook potentially more serious underlying etiology. For example, a patient in CCT who's a little bit hypoxic, and we're overly attributing the factor of obesity hypoventilation, despite maybe they've never felt this way before and they end up really having a PE. Something else that I read that I thought was really insightful was that you can be honest about the limitations of our technology in assessing and caring for larger patients. For example, if you're doing an ultrasound study and the patient's body habitus is making it really difficult to have a good view, you can say, like, I'm sorry, this machine isn't made to work very well in larger bodies. Because of that, I'm going to have to escalate to a CT scan because I want to get the most information that I can. Things like that, being honest. You don't have to pretend that this isn't the case. And then I kind of said this before, but my opinion, based on what I've read, is that you really shouldn't be addressing weight in adult patients in the ED. I wouldn't say the same for pediatrics. I'm not talking about pediatrics here. Everything that I read about was about adults. But there are just so many factors involved in assessing a patient's health, weight, how weight is actually contributing to that person's other disease processes, whether or not they've already had healthy lifestyle changes, if they've already tried dieting, et cetera, et cetera. And we also don't have solid evidence about it being a good recommendation to lose weight. So I think it's better off to make it very clear to your patients that you're not going to dismiss their health problems by blaming it on their obesity, or even worse, blaming it on this presumed lack of self-control or discipline. Um, and hopefully your patients will engage in less unhealthy behaviors because of that, like avoiding medicine due to fear of weight stigma, which there's ample evidence to show that that happens as well. Just like there's an implicit association test for race, there's also an implicit association test for weight bias, which you can take if you're interested. Just some food for thought. So these are some great resources if you're interested to learn more. The one on the left is a podcast by Aubrey Gordon. She also has this book, What We Don't Talk About When We Talk About Fat. I listened a lot to the Maintenance Phase podcast in preparing for this presentation, and I would love to read her book. I haven't read about it yet. I haven't read it yet. And then The Belly of the Beast is specifically about anti-fatness, and its association with anti-blackness. And I have a lot of resources that I gathered. If anyone is interested in learning more, please reach out. I'm happy to share those. Thank you to the Social EM team for all of your helpful feedback, and I hope you all have something to take away from this.
Thank you, Milo.
Thank
Any
you.
questions, comments?
I have a comment. It's interesting because I've had a couple of attendings over the years like tell me I should address people's weight in the ER like as a lifestyle intervention or like, and I never felt comfortable doing that. I think to your point, Milo, like the sense of like this isn't really my place. I don't really know this person and I don't know their life and I don't really know like the evidence for or against it, unless they maybe bring up something like, "Oh is my joint pain due to my weight?" But yeah, so I just felt like it was kind of a weird thing to do.
That was kind of the specific scenario that I thought it might be appropriate. Like you have an adult patient who's on the younger end and they're suffering from osteoarthritis. It's like that might be an appropriate time. It's like pretty straightforward. But yeah, other than that, I think you're better off just making sure that patient is going to come back to the ER if they have other serious health problems and not be worried about you saying things based on weak. I mean, not all of the evidence is weak, some things being weak correlatory evidence.
So, what is the difference in pediatrics then? Like, what does the evidence show interventions in the ER?
So I don't know is the answer. I do know there's a lot more emphasis on talking about weight with pediatric patients. I did read a little bit about there being positive response to weight interventions in the ED amongst pediatric patients. Positive response being that patients did make an effort to change lifestyle and nutrition habits at home after that. I didn't read any data about like negative effects on self-perception and what happens later on down the road if you're exposed to weight stigma as a kid in the ED. I did read that exposure to weight stigma increases your likelihood to become obese if you aren't obese for both adolescents and adults. So if those conversations are to take place based on what I've read, it would just be important that they are straightforward and kind and compassionate and not loaded with stigma, obviously.
Adrian, I think has a comment, question.
Yes. Yeah, thanks for that fantastic lecture, Milo. Very insightful, and I like the way that you organize the structural issues that are in play, and also, how we learn about things through training and how that affects our bias. I just wanted to comment. Personally, I haven't found it beneficial to address, a patient's weight specifically during an encounter when I'm thinking about how effective I'm going to be in, setting them up for a successful discharge. But some things that I do address that might be important is like when a patient has constipation, I might encourage that, I might ask about how much fiber they have in their diet, or how many leafy green vegetables they're eating, how many fruits and vegetables. And if they're not having, high fiber, I might encourage a higher fiber diet. And in general, I think that is something that will, over the long run, contribute to their wellness and their well-being without specifically addressing their weight. So that's one thing that you can focus on that is evidence-based, I would say. And then another thing that I might focus on is, if somebody's having a lot of muscle aches or joint pain, I might ask, how much activity they're getting throughout the day, and I might have a little bit of time to explore whether they have space or time in their day, to incorporate a little bit of exercise, a little bit of walking, always keeping in mind that, a lot of our patients have two jobs or have a lot of responsibilities outside of the clinical environment. So, I always ask, are you somebody that's super busy? Do you have a lot of downtime? And if you do have a lot of downtime and, exercise is something that I think might be beneficial to them, I might say, I might encourage walking. But, obviously for reasons that you mentioned, it might not always be possible. They might not always have a safe environment, but sometimes we do have time to explore, okay, do you have a safe environment to walk? Do you like walking? Do you like moving? Do you do exercise? If so, is there a place in your day where you can incorporate a little bit more? Or if somebody has chest pain, I will often recommend that they do wall push-ups to help strengthen their chest wall, especially if I think it's a musculoskeletal chest pain. So, I guess my point is there are ways to address, being active and eating well without really making their body shape or their BMI the main focus.